All right, let's dive straight into today's clinical review covering fluid, electrolyte, and acid-base physiology. We're picking up the pace and jumping immediately into question 17.
So, question 17 gives us a patient who develops hand spasms when a blood pressure cuff is inflated. What's going on here? Well, the correct answer is B, hypocalcemia. You see, this is a classic neuromuscular manifestation known as a positive Trousseau sign. Now, a patient might actually feel totally fine, completely asymptomatic, if they have hypoproteinemia. But these really visible symptoms like facial paresthesias, muscle cramps, and those carpopedal spasms, they show up fast when the ionized calcium fraction drops below 2.5 milligrams per deciliter.
Moving to question 18, we need the actual anion gap of a chronic alcoholic patient with a sodium of 133, potassium 4, chloride 101, bicarb 22, and an albumin of 2.5. The answer here is D, 15. If you just do the standard calculated gap, you'd get 10. But here's the absolutely crucial clinical catch. Hypoalbuminemia falsely drops the apparent anion gap. Why? Because a normal gap is primarily driven by the negative charge on serum albumin. So we have to apply the corrected anion gap formula. We take that baseline of 10 and add 2.5 times the difference between a normal albumin of 4.5 and our patient's 2.5. This correction safely bumps our actual clinical gap right up to 15.
Now for question 19. What primarily controls the effective osmotic pressure between the plasma and the interstitial fluid? The answer is D, protein. This is a massive foundational concept in physiology. Dissolved plasma proteins basically can't pass through that semi-permeable capillary endothelium. Since they are physically trapped inside the intravascular compartment, they generate this effective colloid osmotic or oncotic pressure. It literally acts like a magnet, holding fluid right there inside the vascular space.
On to question 20, which tests us on the metabolic derangement you'd most commonly see in a patient with profuse vomiting from an obstructed pylorus. The correct answer is A, hypochloremic, hypokalemic metabolic alkalosis. Think about it. Vomiting from an obstructed pylorus, like you'd see in duodenal ulcer disease, causes an exclusive selective loss of gastric secretions. And what are those secretions full of? Hydrochloric acid and water. Losing that directly causes hypochloremia and metabolic alkalosis. Then, your body hits the panic button. It frantically tries to save sodium and volume using aldosterone, which unfortunately forces the kidneys to dump potassium and hydrogen into the urine, locking in that hypokalemia.
Question 21 asks us to identify the exception among symptoms and signs of an extracellular fluid volume deficit. The odd one out is D, high pulse pressure. Actually, a wide or high pulse pressure is a classic hallmark of extracellular fluid volume excess, not a deficit at all. If a patient truly has a volume deficit, you're going to see signs like apathy, anorexia, a drop in body temp, tachycardia, and specifically a narrow or low pulse pressure. Let's tackle question 22. You have a patient with a low urinary ammonium concentration alongside a hyperchloremic acidosis. What's the underlying cause? This points straight to D, renal tubular acidosis. The key pearl to remember here is that a hyperchloremic metabolic acidosis is essentially a normal anion gap acidosis. So, to figure out if the primary bicarb loss is coming from the GI tract or the kidneys, we check the urinary ammonia. A low ammonium level unambiguously tells us the kidney itself is failing to excrete acid like it should, which perfectly confirms an RTA.
Next up, question 23. When lactic acid floods the system in response to an injury, how does the body minimize the pH change? The answer is B, excreting carbon dioxide through the lungs. Let's trace the biochemistry real quick because it's pretty elegant. Excess hydrogen ions from that lactic acid react directly with base bicarbonate to form carbonic acid. Then an enzyme called carbonic anhydrase rapidly breaks that down into water and carbon dioxide. Finally, that CO2 is swiftly breathed off and eliminated by the lungs, keeping that systemic pH nice and stable.
Question 24 asks a fundamental question. What is the absolute best determinant of whether a patient has a metabolic acidosis versus an alkalosis? The definitive answer is A, arterial pH. Look, things like serum bicarbonate, partial pressure of carbon dioxide, and the patient's clinical history, they can all give you strong hints. But direct measurement of the arterial pH, that is literally the only value that objectively confirms whether the patient's overall systemic state is acidemic or alkalemic.
Moving right along to question 25. If a patient's arterial PCO2 acutely drops to 25 millimeters of mercury, what will the arterial pH be? The correct mathematical outcome here is A, 7.52. Let's break down the math so it makes sense. A normal baseline PCO2 is 40, so an acute drop to 25 means we're looking at a 15-point drop, typically from hyperventilation. Now, within standard physiologic limits, every 15-point drop in PCO2 bumps up the systemic pH by about 0.12 units. Take our normal baseline pH of 7.40, add that 0.12, and you land precisely at 7.52.
Question 26 looks for the exception among mandatory clinical indications for urgent dialysis in acute renal failure. So, which one doesn't belong? It's A, a BUN greater than 100 milligrams per deciliter. Sure, an elevated BUN is a totally standard marker of acute renal injury, but an isolated high BUN value just isn't an absolute trigger for urgent dialysis on its own. On the flip side, hyperkalemia, severe acidosis, uremic pericarditis, and uremic encephalopathy, those are immediately life-threatening clinical emergencies that require dialysis right away.
Okay, question 27. Imagine an elderly diabetic patient with acute cholecystitis. Their serum sodium is 122, and their blood glucose is sky-high at 600. After you correct that glucose down to 100 using insulin, what's going to happen to their serum sodium? The answer is D. It will actually increase to the normal range without any specific sodium therapy. Here's why. Profound hyperglycemia creates a dilutional hyponatremia by dragging intracellular water out into the blood. For every 100-point elevation in glucose, the measured sodium artificially drops by about 3 milliequivalents. So reversing that glucose from 600 down to 100, a 500-point drop, naturally and safely pulls that serum sodium back up by around 15 milliequivalents, dropping it right back into the normal range.
Question 28 asks, what metabolic derangement can happen if we give a patient excessive amounts of normal saline during fluid resuscitation? The correct choice here is B, metabolic acidosis. To really understand why this happens, you have to remember what 0.9% normal saline actually is. It contains a really high concentration of both sodium and chloride, specifically 154 milliequivalents per liter of each. Pumping immense volumes of this fluid into a patient dumps a massive chloride load directly onto the renal tubules, and that routinely precipitates an iatrogenic hyperchloremic metabolic acidosis.
Let's look at question 29. What is the very first step in the immediate management of acute, life-threatening hypercalcemia? It's A, correction of the extracellular fluid volume deficit. You see, severe hypercalcemia completely wrecks the kidney's concentrating capacity, leading to intense vomiting and severe volume depletion. Because of this, aggressively restoring that extracellular fluid volume deficit with isotonic saline is absolutely the most critical first step. Rehydrating the patient dilutes the serum calcium and gets the kidneys excreting calcium safely again. And you have to do this before you even think about reaching for a loop diuretic like furosemide.
Question 30 gives us a trauma patient, a motor vehicle accident victim in hemorrhagic shock. They have an arterial pH of 7.25, a PCO2 of 25, and a bicarb of 15. What's the best treatment for this patient's metabolic acidosis? The answer is C, lactated Ringer's solution. Early metabolic acidosis in trauma is a huge red flag for systemic anaerobic metabolism and tissue hypoxia due to hypoperfusion. Pushing alkaline buffering agents like sodium bicarbonate doesn't actually fix the underlying problem. Instead, reestablishing macrovascular volume and microvascular tissue perfusion using a balanced crystalloid like lactated Ringer's shuts down that anaerobic metabolism at the source, giving the body the chance to clear the lactic acid naturally.
Almost done. Question 31. 3 days post-op, an alcoholic male patient starts showing delirium, muscle tremors, and hyperactive reflexes. We suspect a magnesium deficiency. Which of the provided statements is false? The exception here is A. You should absolutely not base your decision to administer magnesium purely on a serum-level lab draw. The tricky thing about magnesium is that serum values often completely fail to reflect true intracellular levels. A patient can have significant total body depletion even if their lab results look perfectly normal. If you have a highly suspicious clinical picture like this, you treat it regardless. Just keep in mind, complete replenishment takes about 1 to 3 weeks of ongoing repletion.
And finally, question 32. Refeeding syndrome can be associated with all of the following electrolyte and metabolic issues except B, hyperkalemia. Think about the physiology here. Refeeding shifts the body's baseline metabolism from an endogenous fat-burning state back to utilizing carbohydrates. This triggers a massive surge in insulin, which aggressively shoves key ions straight into the cells. This causes a rapid and really dangerous drop in the blood,
specifically hypokalemia, hypophosphatemia, and hypomagnesemia. It definitely does not cause hyperkalemia. This profound intracellular shift directly causes severe cardiac arrhythmias, neuromuscular confusion, and even respiratory failure. So the next time you see a massive insulin surge in a recovering malnourished patient, ask yourself, are you completely prepared to manage the silent, sudden crash of those vital intracellular ions?